Good evening, everyone. Thank you so much for taking the time to join us for tonight's presentation on management of equine synovitis, a case-based approach. Tonight's presentation is given by Dr. Cricket Russillo. Dr. Russillo has over 20 years of experience specializing in elite show jumpers and dressage horses. She is ISELP certified and passionate about solving complex lameness cases and optimizing sport horse performance. Additionally, she is a former U.S. dressage team veterinarian and is the founder of High Performance Equine in Northern Virginia. Also joining us tonight is Dr. Meg Green, our Technical Services Manager here at Contura Vet US, and she will be helping moderate tonight's discussion at the end for the Q&A. So you will see at the bottom of your panel, there is a Q&A box. You are welcome to use that throughout tonight and submit your questions as they come to mind, and then we will answer them at the end. So without further ado, Dr. Russillo, the floor is yours.
Thank you. Good evening, everyone. And thank you to everyone at Contura Vet for asking me to be a part of their ongoing webinar series. I've prepared a talk tonight that hopefully is a bit more practical, highlighting a few cases where I've selected Arthromed Vet as my treatment of choice to address synovitis. Technology is not my friend tonight. Sorry. Rachel.
You might have to put your cursor back on the screen with the main slide.
Oh, okay. I apologize, everyone. You're right. Thank you.
Yep, you got it. You're good.
And so while the focus of this talk is not meant to be a deep dive into the pathophysiology of equine joint disease, I did think that a quick concept review could be helpful as we discuss the case management using Arthromed. Lameness due to osteoarthritis is a common scenario in sport horse practice. And as sport horse practitioners, we're all familiar with the results of repetitive stress from training and competition. Up to 60% of performance horses may be affected in one or more joints, and 60% of lameness is related to osteoarthritis. As we care for our equine athletes through their careers, the aim should be to take a more proactive approach, interrupt the cascade of mechanical factors and chemical mediators that lead to the development of osteoarthritis, and see if we can find a way to potentially limit the development and progression of this disease. And so in that proactive pursuit, the major target that emerges in my mind is synovitis, which we can simply define as inflammation of the synovial membrane. And it can be present at any stage of osteoarthritis, early or late. Some of the hallmarks of synovitis include effusion, capsulitis, of course, lameness, but I think it's important to recognize that not all cases of synovitis are associated with effusion, and I've got a case to demonstrate that later. The goal is, in my mind, to protect that natural function of the synovial membrane and eliminate the downstream consequences of the degradation of synovial fluid and the joint environment. Once disrupted, we get a cascade of inflammatory cytokines, production of these mediators such as metalloproteinases, free radicals, nitrous oxide, which altogether, these are the chemical mediators that combine to degrade cartilage. Recently in research, they were highlighting the role of the synovial macrophage in joint homeostasis. And the activation of these macrophages may be the principal driver of synovitis. So if we start thinking about ways to mitigate the effects of training and competition, and we understand that synovitis is a huge contributor to those downstream effects that are the result or associated with the resulting osteoarthritis, then here again is our target for treatment, the synovial membrane. And we have this opportunity to use products to restore joint homeostasis, preserve function of that synovial membrane, thus reducing inflammation inside the joint over time with less insult to structure. Briefly, talk about Arthromed Vet. We have Dr. Meg Green with us tonight, so she's really the person to answer the specific questions, but I wanted to put up a little review slide about how it's working and what it's composed of. They have a target tissue unique in the synovial lining, and this 2.5% polyacrylamide gel will incorporate into that synovial membrane. Once injected, that incorporation happens through cell migration and vessel ingrowth to result in a thick cushion-like membrane inside that synovial membrane. This allows increased tissue elasticity and an increased range of motion. Another byproduct of this integration is an increase in the numbers of the synovial macrophages, which we know we need in a healthy joint. So with this rationale for the use of polyacrylamides, knowing that their target structure is the synovial membrane, and we know that the synovitis is originating out of an imbalance in the synovial membrane, the advent of this Arthrimid Vet product really makes sense, and know that it will ultimately integrate into that synovial lining over about 4 weeks' time. A bit about my use of the product, I'd say that I was an early adopter. I have been using it for quite a while. I had the good fortune to overlap with European colleagues who participated in this early 2015 study that was a multi-center and really the first to establish the validity and efficacy of Arthrimid in equine joints. And that was a study that really looked at osteoarthritic joints, like more of an end stage approach. And that was for sure how I thought of it in practice for a long time. But more recently, I'm moving it into the earlier stages and thinking of it even as a frontline approach in my ability to address synovitis. And the more recent study that came out with this comparative, I thought was really helpful for me as a practitioner to get a little bit more buy-in on how I could reach for Arthrimid a little sooner. This is an interesting study to look at and compared Arthrimid against a triamcinolone HA model. And part also of that study that I found appealing as sort of a ambulatory sports medicine practitioner was the way those horses were returned to work right away. Well, I think there was a 48-hour waiting period, but a more traditional approach to joint therapy as compared to the way it was rolled out maybe originally in that 2015 study. So next, I'm going to go through a few of the recent cases I've had where I've opted to use Arthrimid for my joint therapy and walk you through the diagnostic and sort of process algorithm that I came to that conclusion. Our first case tonight is Nike, who is a 2010 Westphalian gelding who's used for dressage. He's a regular patient of mine, so he was presenting for sort of a routine performance exam, which we do on him twice a year. Excuse me. Some important history on Nike is that he did have a previous diagnosis of an osseous cyst-like lesion in his left front, sagittal groove proximal P1. What I noticed at this exam was that he really had this profound effusion of the right front fetlock, which had progressed since the last time I'd seen him. So some close-ups here of his leg. I mean, that is some massive effusion. You can clearly see. See if I can get my pointer to play. You know, even just mounting from the front approach of his joint, you can see it clearly. Okay, so I'm going to attempt to show a video, which I always feel is a little bit, an exposure because you and the audience are going to be like, what does she mean? It's totally lame. I didn't think he was so lame that day. And I really don't like watching videos. I think it's hard to assess lameness by a video, but nonetheless, here I am showing you the video of Nike. And this is sort of my first, everyone does their own thing, but for me, I'm going to start moving them in hand on a firm surface here. So that's Nike. And then here he is again in the indoor. And I know everyone does things a little bit different on this day. This is how, and I do things differently day to day, but this is how he presented this summer. So for me, on that day, I assessed him to have a mild right front asymmetry. I didn't think there was like a consistent blockable lameness. I did run through all of my flexions as part of my exam, and I don't have a video of that here, but I thought it was a mild plus, like a couple steps that made him a little bit more consistent, but, quickly back to a baseline where no real overt lameness on that right front. And again, with that history of the left front having an osseous cyst-like lesion, plus what I could see clinically in the leg, and then with the overall exam findings, I really just wanted to look deeper and understand what was going on in that fetlock. And so I elected to do some better imaging, some radiographs and some ultrasounds. And so here are some of the radiographs. And, this is a 14-year-old horse who's been competing quite some time. And I do think there's arthritis in that fetlock for sure. I'm not just disputing that. We've got some change of proximal P1 dorsally, some, lipping on the margins of the joint. But what I was really focused in on is what was going on in the health of that sagittal groove. And hopefully that image shows it a little bit better. But in my estimation, as I thought we were starting to see some more lucency here, and that he might also now have the same mirror image diagnosis that he had in the left front with a subchondral cyst-like lesion. And, all of that for me explains why this horse had that progressive synovitis in his fetlock. So then full imaging, I wanted to do an ultrasound. It is a dressage horse, make sure there's not a soft tissue complication. And, what for me stood out, less, worried about his branch, but just some effusion and a lot of proliferative synovitis evident. This is again a look at, this is now looking at it from the lateral side. The previous image was medially, but what I've done is I've switched my probe orientation. So actually this is a longitudinal, and that's like the edge of the branch. And this is just, because I think sometimes when you spin the probe, you really can get an appreciation more in longitudinal for all this proliferative synovium that's hanging out in that fetlock joint. And yeah, there's a little bit of fluid here, but it's not that impressive when you think about what that leg looks like. This is just a true synovitis with proliferative synovium. And in my mind, a great opportunity to use ArthroMedVet. I've got proliferative synovium. I've got a product that's going to go and attack that. Attack's the wrong word, sorry, but its aim is to integrate into that synovial membrane and help attack the inflammatory process that's resulting from this inflamed synovium. And indeed, that is what I did manage him with. So we'll move on to my next case. This is Ziva, and she's probably like a 180 from Nike. This is a mare who was about 4.5 the time I saw her. Recent import to the United States, mare just coming into training, also meant to be a dressage horse, but instead of having an aged competition horse with sort of long-standing wear and tear, here is a horse at the beginning of her sport career. And she was just about, like I said, 4.5, had been in the country maybe about a month, had sort of settled in after riding her, more consistently. The new professional had some concerns that maybe she wasn't as comfortable as she needed to be, and didn't want to keep pressing a young horse that might have some body soreness, and so asked me to go over her. And I don't have a video for this horse, but there was not a significant lameness. She's quite sound. When I went through the flexions, what really did stand out to me, though, was a profound stifle flexion response. And I thought that was moderate. And so here I had this basically 4 weeks in the United States, had been vetted by a trusted colleague. She had assessed the horse at sound, no flexion responses, had looked at the radiographs. I had looked at the radiographs. There was no OA in that stifle joint. So I felt like my next step here was going to be to pull out my ultrasound and take a look at her stifles. And I spent some time and just selected for you a couple of key images from that scan. But, again, here we have some effusive synovitis, but proliferative synovium, thickened joint capsule. These are the medial femorotibial joints. She also had effusion and synovitis in the lateral femoropatellar joints. The lateral femorotibials looked fine, but this was for me, like I thought the explanation for those stifle flexions, and here faced with a horse just getting started, wanting to shut down that inflammatory process and really restore joint homeostasis, I thought she was a great case for Arthrimid, and used it really successfully for her so that she could return to training and settle down those stifles really nicely. I have one more case for you tonight to talk through, and I realized tonight when I was rehearsing one more time that apparently these are all dressage horses, and I promise I take care of other horses too. But here again, a dressage horse, and this is Everest, pictured here with his rider and owner, all fancy-like for a show this summer. Everest is a little bit older horse, 2009 warm blood gelding, who I was evaluating as part of a routine soundness exam. This one, he didn't have a baseline lameness, but what really stood out was the way he resented the flexion of his right front lower limb. And so in an effort to show that to you a little bit better, took this video. And right or wrong, when I see this, you pick it up, pull back on the toe, and the horse like pulls away from you, really sort of argues. I really think in my mind that there's some capsulitis or fibrosis going on in the fetlock. And again, this is just my takeaway. Certainly, it's not 100% accurate for every case, but it does make me start to wonder about something in that realm. And so I talked with Lucas, and he was willing to let me do a little investigation. Before we get to that, here are some pictures. So this horse, from the side, I think hopefully you can see actually quite good demarcation, of the bony and soft tissue structures. This is not, like, compared to Nike, this is not a really effusive fetlock joint at all. Maybe there's some mild distension, but there's a concavity there. There's not a lot of big distortion of the joint. Radiographs, certainly we do have some osteoarthritis in this fetlock. Again, he's 15, so is that appropriate or not? We could argue, but it's evident that he has the arthritis. What was less evident was, is it inflamed and bothering him? I have this suspicion based on the flexion. And so searching for that explanation, put the ultrasound probe on him, and really, again, synovitis, proliferative synovium, in this case, really not a lot of fluid. And I think these are the joints that can be a little frustrating to inject. Even Nikes, if I go back to that case where you've got all that proliferative synovium, you don't necessarily get a lot of fluid coming out of your hub of your needle. I think with Everest, you could, there's very little fluid here, but a lot of thickened synovium. This is edge artifact, I promise. The branch was okay. Just this snapshot, more focusing in on the synovium here of his fetlock joint. And so 15-year-old horse, osteoarthritic, some fibrosis of the joint capsule suspected, and obvious proliferative synovium and synovitis. He was, in my mind, a great opportunity to use Arthrimid, and that's what I did. So in summary, synovitis is a great target if we're looking for some way to preempt the causal factors that lead to osteoarthritis and manage osteoarthritis in cases that are in our older competition horses. And if synovitis is our target disease and our target tissue is the synovium, then this product, Arthrimid, is really awesome, because here we have a way to interact directly with that synovial lining and introduce a treatment option that can address that directly. No, thank you. I see we've got one question. Rachel or Meg, who wants to lead on?
Well, thank you, Dr. Russillo, very much for your for these cases. This was a great overview. I think just really honing in on the target tissue and really how the synovium plays a huge factor in OA. And so I think, what you've shown in these three cases really presents that in a very dynamic way. And so I really appreciate you taking time to go through that. We do have one question at this time, and it actually is going back to Nike specifically. And their question is, does Nike's fetlock swelling change at all in relation to arthrimide, less, more, or any, being that the mechanism generally creates a thickened synovium?
And so I actually just rechecked him this week. And so the answer is no. He's got still that same profile to the leg. He's sound and in training and doing well. I don't know that for me, I'm bothered by the profile as much as now that I understand what's going on. And, maybe that profile led me in a direction to investigate and see, oh, this horse has proliferative synovitis. Why does he have proliferative synovitis? He's got an I think there's an osseous cyst-like lesion. So I don't think I can, keep that from being a continual source of inflammation for that horse. So in that way, I don't expect it to completely reverse. But if I can manage it and keep ahead of it, then I'm happier.
Okay. Another question in regard to that is, can you describe the character and the consistency of joint fluid before and after?
And there have been horses that I've had the opportunity to treat multiple times. And the joint fluid pre-treatment is quite watery. These synovitic, if that's a word, fetlocks, like the ones I'm showing you, like Everest and Nike, in my experience, it's not a lot of fluid. Like I mentioned, they're not just like pouring out fluid. But the ones that are just more of a fluid associated effusion, like Ziva stifles, yeah, you'll get watery fluid that just sort of pours out of those joints. And then if not so much in like a Ziva case, because I have not treated her a second time. I think we chose a good product. We arrested the disease process pretty well for her. But if I have more of a long-standing OA case and I am in one of these where I'll series some different products, I'll use the arthrimide. I might use another orthobiologic because my target is a different tissue type in that joint, like the cartilage. I've seen a restoration of a better viscosity. And so I sort of feel better when I do that second, or maybe it's the third treatment on that joint, and I put the needle in, and instead of that voluminous watery fluid, I get something with a really nice string and thickness, or it just fills my hub. It's not like falling onto the floor in the wash rack anymore.
Excellent. That actually leads us into this next question, which I think you'll touch on. And one of the questions is what is your injection protocol? And then frequency of injection when you inject with or without a steroid or an orthobiologic? And what is your time to return to work?
Okay. So injection protocol, I think, is very case dependent. If there's lameness, for starters, it's going to be a different return to play. But let's take a horse like Everest, who I'm looking at. It's a sound horse. We're just trying to optimize his comfort. I would sterile prep, sedation, inject the joint. And that was a fetlock. So I will say, anytime I inject a fetlock, I get a little bit obsessive about the potential introduction of something that could expand the volume of the joint and then create swelling. And I don't want what my clients are seeing to be like, oh, she came and now the joint looks bigger. So I will wrap those joints for 48 hours. I'll ask them to leave them in a standing bandage. I'll ask them to ice it twice a day for those same 48 hours. I hold the horse in for 24 hours, but then it can go back out. And I do give it a total of 3 days off. And that's sort of my routine immediate aftercare on a fetlock joint, but the same 24 hours in a no turnout, then allowed to go out, and 3 days rest is a very customary after joint injection protocol for me, any joint. Again, I just get a little, I like to watch those fetlocks because a lot of times they are inflamed. And so they're sort of poofy already, and I don't want them to get bigger. So the icing and the bandaging really helps control that. I think it also forces clients to look at their horse's legs, and if there was going to be a problem, they're going to notice it sooner, where you can maybe intervene a little bit more successfully. If the horse is lame and I'm using products like Arthrimid, maybe in conjunction with something else, like that horse is probably going to be walking only between injections. And I have done usually about a 2-week interval between intra-articular treatments would be my pretty typical. So walking time 0 to day 14, next treatment, same in for 24, 3 days off, and then resume light exercise and progress. I think I touched on all those points. Did I miss something, Rachel? I'm sorry. Meg.
No, I think one of the things that I would go back to in regard to, you know, with the treatment protocols and kind of clarifying a little bit about, do you use anything concurrently? You know, if you're doing those injections in between, is there something that you utilize initially and then follow back at that 14 days if you're doing multiple injections? If so, what does that look like? And sort of how do you make that assessment as to what product you might use? Like whether you use Arthrimid first or whether you use another product first and then come back with Arthrimid, or vice versa.
Yeah. So I've not so often paired it with steroid. I have done a few of those, you know, when I'll use that maybe in more of my FEI competition horses. I'm looking at them. I've got a moment in time that I'm going to see them. I know that they need to get off to a horse show and they're going to be competing for several weeks and I'm not going to be near them. So in that moment, I'll pair the betamethasone, which is my preferred joint corticosteroid, with the Arthrimid in one treatment session, one needle, 2 products. And then I feel like I'm going to gather a little bit of that immediate onboarding of the corticosteroid. And then I know from that study, that 2021 study in New Zealand, that Arthrimid is going to be building in the background, you know, and by week 2, there'll already be some good effects onboarding when maybe the corticosteroid is starting to wane. And then the Arthrimid will be building even further out into its full response, you know, in that 4-week time frame. And that's been very successful for me in that one moment where there's a single injection. If I have well, like Nike, where you're recognizing there's a subcon or possible osseous cyst like lesion, thinking I need to do something more stimulating healing, not just managing a synovitis, I will stage sort of a approach to normalizing the joint homeostasis with something that's more orthobiologic, try and like calm the joint down, get some growth factors in there. And then at a 2-week mark or whatever time I feel like rest is necessary, if it's, you know, not Nike, maybe a lamer horse, I would then add the Arthrimid when I'm ready to put that horse sort of into a progressive exercise program. So again, sort of capitalizing on it's going to be building over time. I want it in there, but if I can, in sort of in partnership with another product, introduce something like an orthobiologic for more of the disease modification aimed at like the cartilage or the bone issues. And then the Arthrimid is sort of the second step. Does that help?
Excellent. That does. Thank you. One thing I might add to just what you said in regards to the betamethasone is one of the things that we have recently submitted for publication and is an abstract and a manuscript for our concurrent use study specifically with betamethasone, 6 milligrams of betamethasone plus Arthrimid vet in normal horses into their fetlocks. And so we had no adverse events that occurred with that. And so that will be coming hopefully soon, but we can certainly share that, you know, with regard to that we do have a research specifically utilizing betamethasone and Arthrimid vet at this time in 10 horses that were normal as far as that's concerned. We are, you know, looking at potentially doing additional studies in the future with concurrent use with orthobiologics down the road. And so, you know, I think, you know, as we gain more traction and understanding this product, you know, more and more, one of the biggest studies that we have that is currently going on right now is with Colorado State University and Dr. Katie Seabaugh and Dr. Aaron Contino that are the co-PIs on this particular study. And it's actually utilizing the carpal chip model specifically. And then we're also doing some adjunct different evaluations, specifically looking at these inflammatory cytokines and looking at RNA sequencing, but also being able to look at the different types of cytokines and doing a multiplex assessment with 23 different markers, specifically looking at that. And then we're also looking at the nerve evaluation, as far as looking at the nerves and staining them specifically to make sure that there is no morphological changes or anything associated with that. And we're also continuing to evaluate these horses and at a later point in time, we aren't doing it in this particular study, but looking at the dorsal root ganglion that we'll do at a later point, where we're harvesting those with this particular study to look at pain modulation with these horses. So we're really excited about to have that information that'll be coming in 2025, likely in the second half of 2025, once the evaluation and everything with the data is finished up and that kind of thing. But stay tuned for that information, but something we are very excited about. And we continue to reinvest in our, the research that we're doing and trying to understand this because we know that this is something that is very unique in the way that arthromed works. And so we want to really try to understand this more and more. So the next question actually is dealing with dosing specifically. And the question is, how many syringes of arthromed do you put in stifles versus fetlocks or any other joint?
Yeah, I have been, well, so I'll say what I would likely suspect is ideal is not necessarily affordable for many clients. So I am a little leaner, but I still see effects. So I'm happy with the results that I get at these typical doses, which is a 1 syringe for a fetlock, a pastor, and a coffin joint. I will use 2 syringes for a stifle. And I must say, I don't often use it in hocks. It's not something I reach for. I don't think maybe I'm missing a great opportunity there, but I do like 2 doses in a stifle for the volume. That's such a big joint. And as Meg has explained to me, that arthromed, once inside that joint, it's going to pick a piece of synovium that it's going to bind to and integrate into. It's certainly not going to resurface the entire synovium. So when you think about what those joints look like on the inside, and certainly 1 ml is not going to be covering much territory. And I think more is probably more, but even just the small dose that I'm using, I am seeing good results.
So with that comment, I think that's important. It kind of leads it to another question, is specifically talking about re-injection. And have you found in the cases that you've treated, have you had to go back in with arthromed? And if so, how much volume? And then what's the frequency, the time span between injections?
As a practitioner, I'm not really excited when I have to go back into a joint, in a less than 3 or 4 month timeline. But then I will turn around and say to my client, well, we have to manage this joint inflammation, and at least we have something that we can be responsible with and know that we're not creating deleterious effects in the joint. So even if the choice is, well, you cannot ride your sport horse and continue competing, or we can be responsible and manage the joint disease, at least I can lean on a great product like arthromed to know I'm not going to be deteriorating this joint further. I think sort of going back to how I've seen joint fluid characteristics change over time with the use, when you get that joint environment happier, you'll see extension of your joint intervals as well. So I'm thinking of a high performance dressage mare who will get that same resistance to the lower limb flexion. She will have some notable synovial distension in her fetlocks. And I was historically treating that fetlock I think I went like 3 months, then I went 4 months, and then we recently went 7 months. And she's been at the same level of training this entire time and actively competing even more intensely over this last 7-month period. So all those treatments were with arthromed. So I guess I don't hesitate to retreat if I feel I need to. I do want to second, audit myself. Do I have the right disease process? Do I understand what's going on here? Like, for example, am I missing some suspensory branch desmopathy, which is creating instability in the joint? So I don't have a complete diagnosis. But if I feel I've got the right diagnosis, I am comfortable repeating injection. And I have been pleased with the lengthening of the retreatment interval in these successful cases.
I think that's one of the keys, what you just said is, what I find in talking with veterinarians and utilizing this product is if they do have to redose, is really being able to look at that case selection and making sure that you do have the proper diagnosis, and being able to evaluate those horses and going back and don't being afraid to utilize your ultrasound, utilize your radiographs, and being able to evaluate, because we know that this is a progressive disease. And I think that's one of the areas that how this product integrates into certain portions of the synovial lining, and it's not, to what you said just a moment ago, it's not uniform, it's not going to coat the entire surface. And so where it gets integrated to, on day one of injection, it's going to integrate, and depending upon the volume that you actually put into that particular joint, as well as the disease state, are we mild, are we moderate, are we a severe case? And that's all going to be determined based on each individual case that you're treating. And so depending upon the volume that you're putting in, you may end up having what I consider to be a partial responder, which happens in about 15% of cases. And it may just be related to the volume of that was actually originally put in. You put more volume in it, reattach, and it's because we know this is a progressive disease, that today you're at stage 1, and then now you're going to come back and say 6 months from now and reevaluate that horse, and make sure that you still have that same diagnosis if that is the case, and it is synovitis, it is OA, and not something related to soft tissue, then you can go back in those cases. And I do think that we do see a lot of success in those cases. And to your point, I do think the intervals increase with time. And so kind of getting out of the mindset of coming back every 6 months. It's fine to do these performance evaluations, I believe, but a lot of their trainers, as we all know, have kind of gotten into that. It's time to do our hocks, it's time to do our stifles, it's time to do our fetlocks, because they've been in that habitual case because of what the other products that we've utilized for so long and what their time intervals have indicated for that. And so they don't have the longevity associated with that we do see with horses that have been treated with Arthromed. So I think that is one of the key things that I often talk about with practitioners when they're utilizing this product is reevaluating. And there's nothing wrong with reevaluating these horses and doing those performance exams. It just doesn't always mean that those horses are going to be lame, and that we have to go back in and just retreat because it's been 6 months, but just continuously evaluating these horses. So the next question is actually specifically looking at, are oral NSAIDs contraindicated in conjunction with using Arthromed, i.e. horses on daily equiox?
To my knowledge, and Meg, please correct me if I'm wrong, there's no reason why you could not concomitantly use a non-steroidal systemically in these horses. I will use a dose of Banamine at the time of injection. I would say, more often than not, but not necessarily every time. And the factors that influence me, we could get into, I suppose. But again, if there's a really irritated joint, I think a dose of Banamine to help the injection process not stir up too much inflammation on top of when I'm trying to control it makes sense. I don't leave horses on anti-inflammatories as a matter of my post-treatment protocol. So only one dose maybe at the time of injection. As far as horses being on Equiox and getting Arthromed, unless Meg says differently, I think that's probably compatible, but my aim, I would say, is I'm trying to find something really specific that I can treat on these horses that alleviates the need to be on sort of a regular Equiox dosing. So my goal is to not necessarily leave my horses on Equiox. And so that's just me trying to do the best I can, which might not always be realistic, but I do try.
Sure. To your point, there is no contraindication, specifically because there's no pharmacological activity. Arthromed Vet is considered to be a medical device, and so its target tissue is a synovium, and it doesn't actually leave the synovium once it's integrated, and really becomes part of the native tissue of the synovial lining where it's integrated. So because there's no pharmacological activity, utilizing an NSAID, at the time of therapy, but also you continuously using it is not contraindicated. I think the biggest thing to what Dr. Russillo just said is really making sure that how do we manage these horses effectively and utilizing the targeted therapies, that we are treating these joints appropriately and being able to manage them in in that way, I think is really important. And is it necessary to continuously keep them on, a daily NSAID? I really think it really has to do with the age of the horse, the age of the disease process. We all know that it doesn't, just age of the horse doesn't always correlate to the age of the disease joint per se. And so the wear and tear on what's happening with that horse and what's going on with those joints is what's critical at that point, and really what the intended outcome, intended use for that particular horse, and managing those expectations with those owners and trainers appropriately.
Meg, if I could just piggyback on that, I think, and something you said on the last question about the recheck, there's huge value in reassessing these horses. You've come up with a plan, you've decided that it's a appropriate horse to treat with Arthrimid. We've talked about how that it onboards slowly, but it does reach its desired effects probably around 4 weeks would be the time, in my experience, where I'll say, I'm going to see you back. I want to make sure we got what we wanted. I think you could then consider, did we have a complete diagnosis? If we still have a question, or if we have the right diagnosis, did we get the right response? Do we need to retreat? I would be comfortable treating another time with Arthrimid if I felt like I just didn't get enough of the response. Assuming it's going to work is not really a good plan. So, that recheck at the wellness sort of performance exam at the 6-month mark, or whenever competition seasons are about to maybe kick up again and the trainer says, hey, I want you to run through the horses, those are great. But I think when you've had a concern about a horse and you've made a decision to treat a particular disease process or lameness, it's really important to try and get back and look at that horse at the timeline where you think your expected desired response would be on board.
And I think you're 100% accurate in saying that. The other thing too, I think historically, I know in my experience is that because we've had so much like we've been utilizing steroids and HA for so long, we sort of have that time frame in which we know that they're going to start to wax and wane in some of these cases. And so one of the things I often coach practitioners to when utilizing Arthrimid Vet is, really taking that opportunity to reevaluate at that 4 to 6 week mark, because I do think that these horses and what you're going to see, those improvements will change in that period of time that you may not actually have seen, with those horses in that, with previous injections or more of the traditional therapies. And so, getting your eye comfortable, seeing those patients again, and really talking to the owners and the trainers about why you're doing this is because it is a newer therapy, and really understanding how this integrates and to evaluate those patients is really critical for your key learning as you start to utilize this product more and more. And that's something that practitioners have shared with me across the country, that has really changed how they're utilizing and what they're seeing in their patients of, how different it is. And also being able to educate and set their clients up and set those expectations of, this is not going to necessarily happen overnight, like what you've seen in that first 72 hours, because this product has to integrate. And, ideally we see changes within those, first 14 days, but they continue to get better over time. And so that's one of the things that I think is really helpful when you're speaking with owners about this and trainers to help them understand. And that education is different than what we're utilizing with other products on the market. So I think that's really key, is understanding that too. So we have another question that's regarding utilizing Arthrimid and also using other products together. The question is, have you injected with Arthrimid and at a later date injected with an amnion product and later injected again with Arthrimid? And what orthobiologic do you most commonly use after an Arthrimid injection?
Right. So I have used, I mentioned before, certainly a cycle or a series of injections in a particular joint using different products. And honestly, I don't usually do 2 Arthrimid as much as I might do something before the Arthrimid to really sort of calm the joint, so that my Arthrimid might be more effective. Again, thinking about it's only going to pick its little bit of synovium, and if I can calm that joint down, I might have a better joint environment for it to work and be more successful. So I've used it with Alpha 2 EQ. I've used it with ProStride. I've used it with Stridaflex. I don't think I've used it with PRP, but I have certainly used it with a number of orthobiologics. As far as what I most commonly use, I don't think I can say. I really try to curate my treatment protocol to the disease process I'm staring at. So if it's a a horse that just came back from an MRI, excuse me, and I can see that there's a cartilage defect, then I'm more apt to cycle that with something to strengthen cartilage. Whereas if it's just synovitis and osteoarthritis, I might go a different route. So the StridaFlex product, which is the one I've used as far as amnion, I have used in conjunction with the Arthrimid, and I would put that first because I'm looking to sort of correct the disease or modify the disease process as much as possible with those exosomes and those extracellular vesicles and all of the activity that they can stir up. And I think of that as really needing a lot more time. And then when I'm maybe getting closer to increasing the horse's workload, I'll add the Arthrimid and sort of start them into, keep with their tack walk. And then maybe closer to the 2 to 4 week period when the Arthrimid's probably onboarding a little stronger, start in some light exercise and build from there.
Excellent. So I do have a couple other questions I'd like to that often come up, but I'd love to pick your brain about too. One of the questions is that I often get, is traditionally polyacrylamides in general have been utilized more in late end stage. And with Arthrimid, it's labeled for all stages of OA. And we know that synovitis happens in all stages. And one of the things you mentioned earlier in the presentation tonight was how you originally used it more at end stage. And so what sort of made your mindset change to start considering it as a first line of defense?
I think honestly, understanding how it's working better, the target tissue being the synovium, helped me recognize, well, wait, synovitis is just as present in the early stages as it is in the late stages. I think the way it was sort of rolled out and I got exposure to it, as I mentioned, I was lucky enough to be literally standing at the ring next to Mark Kona, who was part of that multi-center study. And he's like, this is some great stuff. We've had great results. And so, I think unfortunately every new product gets put out against the worst cases. And so, here was something that maybe could restore some athletic use to a horse that we thought we really were done with. And so we started there. And then the more familiarity you have with it, you think, wait, I can start using this sooner. And then, as I mentioned, that study on the racehorses where I guess I had it in my head that because of that original work, I really wanted to rest these horses. And again, they were lame horses. As I said, a sound horse, when you're doing a more of a performance treatment to try and optimize, that like extra 3%, those horses have a couple of days off and then they go back into training. Whereas the case selection that I had been guided towards for these real profound osteoarthritic lame horses and using the Arthrimid vet, those horses were in a rest program while it took effect. So when I switched to seeing that it's could be effective in an acute synovitis in a non-lame horse, then you see that it starts to gain traction in your case selection and it starts to creep in a little bit earlier. I think there's also, it's an expensive product, but if this one-time treatment is maybe going to be so successful at mitigating the inflammation that I'm not coming back again and again, then that's a better investment for the client. There's certainly a lot of ease when you're traveling, as some of us as sport practitioners do. You're working out of a suitcase. Arthrimid Vet is a great product to stick in your suitcase because you don't need your centrifuge, you don't need the orthobiologic. It's a little trimmer, easier. So there's all these sorts of practicalities that might, really in concert now influence my choice. But fundamentally, I'm trying to think about what my target tissue is and what my disease process is and what's going to be the most successful to get this under control. And the Arthrimid vet has come in earlier now as a result of that and understanding its true benefit on synovitis.
Excellent. Thank you for that. I appreciate that. One question that has come in since earlier is, one of the questions is, do you still utilize hyaluronic acid when treating your patients?
Yes, I use HA with corticosteroids. I'm not a fan of using it by itself. I will admit that I had, when we didn't have orthobiologics and we had Cushingoid horses, that was something that I would sort of maybe try when I was really stuck. But I feel like now I've got some good options where I don't have to do that. So my HA use is in conjunction with corticosteroids in joints. And I have a pretty strong like all my life, all my practice life, I've used the high visc product from Boehringer Ingelheim, and I just like its reliability and the way it's packaged. And I will add my corticosteroid directly into that syringe, and that's what I'll use if I'm using HA. I'm not so much of a mixer of products, right? As I mentioned, I'm more recently have tried some of these betamethasone with the Arthromed Vet, as Meg has convinced me there's data there. I'm not going to create a joint flare, and it's safe to do that. That you're not going to negatively interact with each other. So I think that might be maybe more of a cocktail that gains a foothold in my practice, but I'm not much mixing things otherwise.
Totally fair. Another question, and you kind of touched on it in your previous response in regards to some of the client conversations, but I think it would be helpful if you would share kind of how you've had the conversations with your trainers and your owners in, getting them to, understand Arthromed, and what are some of the key factors that you share with them that's different about this product than what you've traditionally used on a more conventional level.
Yeah. I think I spend a lot of time talking to my clients. I find that if I can invest that initial conversation, and maybe it's a longer one, but if I bring them along through sort of my process, then they've got buy-in, and I answer their questions. And when we get to maybe the second or third eval in the horse's career, those conversations go a lot faster, and it builds a lot of trust. So right or wrong, I try and explain a little bit about, the a la carte menu and all these options that are on it these days, and emphasize what my concern is in their horse. So, hey, Lucas, Everest has this proliferative synovium in this right front fetlock, and I don't think just a dose of steroids is going to do it. And I really want to, so I'll explain why I don't think a treatment's maybe the right choice, and use that as a comparison to where I think the Arthromed Vet is a great choice, and how it's, in contrast to something that might not have the staying power, might not have the disease modification. Here's this product that, look at this ultrasound, see that target tissue. Here's this product that's going to go right in there and address that. And, I'll have clients ask me when we finish a workup and I'm talking about something like, oh, you're going to use the Arthromed again? And I'm like, sure, that's a great idea. Let's do that. I'd like to think if you educate your clients, you can really elevate your practice.
Do you feel like when you're talking to them, do you ever talk about sort of the bioscaffolding that happens with the structural support specifically with Arthromed, and find that they understand that concept?
No, but I probably should. The words I'll often use are like it knits into the joint and helps restore elasticity. And I think elasticity is something that clients can relate to, like a stretchy, if you can find like another analogy, like a balloon, or a lot of times I'll look at a lead line or something when I'm trying to talk about like resistance or stiffness. And I think a bioscaffold is a great word, and it does make sense. And in fact, putting together this talk, I feel like some of the graphics that you all have available to us as veterinarians can be really useful. It really shows, sometimes it's that proverbial picture is worth 10,000 words, right? So here, client, here is synovial membrane, here's product, this is what's going to be achieved. I think that really helps explain things too.
Absolutely. And I don't know if you were aware or not, but we recently had our equine mechanism of action animation that we've added to our website. And so that is a really great tool and resource for clients to be able to visualize. And I've shared it with many veterinarians across the country, and had really great conversations. When they see it, seeing is believing, to your point. And once they understand it, it makes their conversations a lot easier. But also when they send home their horses and that kind of thing, or if they're having a moment where they're in between lameness exams, it's a great tool and resource if you put it on an iPad, or are able to, or even have them pull it up on their phone and they can actually see it while they're waiting, and that kind of thing. So that's something as a resource. It's on our website, arthromed.com, and you can see it there, and we'd be more than happy to send it to you as well, for anyone that's interested. And feel free to utilize that on your social media, have your clients take a look at it. We're happy for you all to utilize that as well. So we have one last question, I think, before we wrap it up. And it says, would you be willing to advocate for polyacrylamide injected as a arthritis preventative?
I guess my cheeky answer is I think that's what I've sort of the point of my talk is if we manage synovitis, my hope is that we blunt that whole cascade of mechanical factors and chemical mediators that lead to the development of osteoarthritis. I think what you're saying when you say controversial conversation here is, am I going to suggest a preemptive injection of joints before a horse goes into training or something like that to say, we know we're about to induce some inflammation just as a stress of loading and, adaptation to exercise. That I don't think I would go that far. I more would say, I'm really excited in my practice. People want me to meet their new horse. We get that baseline exam. I get a good understanding of what that horse is sort of, operating on as far as conformation and maybe tendencies and weaknesses are identified. And then we follow that along in their career and monitor and make preemptive decisions when we recognize changes. So in that way, I'd like to think that I am preventing arthritis, but maybe not exactly in the way your question is.
I would wholeheartedly agree with you, Cricket, because I think that's exactly we don't want to preemptively give something that it's not indicated for, but certainly doing those baseline exams is really, really critical in any patient, and I think that is the key and the hallmark to any treatment plan, whether it be with Arthromed or anything else, and understanding sort of where those are. And I think as we've gotten better with our tools and resources in our toolbox, if you will, with regards to diagnostic imaging and that kind of thing, I think we have opened ourselves up to being able to provide better imaging quality to evaluate our patients and then also do it more frequently in a way that allows for us to see those changes. And certainly with these performance exams and including that on a more routine basis. Many of these horses, as I'm sure in your practice, you're seeing that you're in those barns rather frequently. And so if there is, one hair out of place, you're going to be called in to evaluate as horses. And I think being able to have those conversations, and I think your approach to being able to take the time to educate your clients, in this manner is so critical, and really helping them understand. I find that, even in my own experience, with, clients myself and talking with veterinarians, is really they want to learn more. And as we know, many of our equine clientele is very educated. And so the more science, the more resources that you can provide for them, the more they appreciate that. And I think that really that helps to allow for foster the education and the development, and really prevents them from going to, say, the Dr. Googles of the world, and really helps us to be able to, facilitate and give them the appropriate information and direct that, their searches and that kind of thing.
Thank you, Dr. Russillo, so much for sharing those cases tonight and your experience and expertise. They were all super insightful. And I know you said you don't love videos, but I think in this type of setting, they're super helpful. So if any of you want to go back and look more at those videos or with some of the imaging that she shared, you'll get a copy of the recording tomorrow that you can do that with. And thank you, Dr. Green, for just being able to have a discussion tonight. I think that's always super helpful. And for all of you taking the time out of your evening to attend, we're so grateful. Our next webinar is going to be on Thursday, November 14th with Dr. Sarah Lejeune, and she's going to be talking about treatment of cervical joints. So I encourage you to attend that one if you're interested. And thank you all so much. And Dr. Russillo and Dr. Green, we're so grateful. And everybody have a wonderful rest of your evening.
Thank you, Rachel.
Thank you, everyone.